When you check an X-ray, start with the margin of the examination, the abdomen, thorax, the soft tissues. Then you check the cardiac silhouette and the diaphragm in addition to the bones. You assess the mediastinum for widening or abnormal configuration. And the AHA, which is the apex, hila, the heart, and the abdomen, which is the subdiaphragmatic area. So always ask if previous films exist. So our best friend is the old radiographs. And remember to beware of the SOS syndrome, which is the satisfaction of search, or the happy eyes syndrome. So I give you an example of the SOS. So you see that this is an X-ray of a patient who had multiple bilateral lung nodules. So probably when you read an X-ray, you will just focus too much on the X-ray, on the findings in the lung. So you will miss that there is, you see a left breast shadow, but there is no right breast shadow. So the patient had mastectomy. They like it very much in the FRCR examination, this kind of case. So you see on CT scan that there are a lot of metastatic lung nodules, but the left breast is present, the right breast is absent. A woman will think of a bracelet. So there are, somebody call it eye. So there are different, nobody can, no two persons can agree on what is this. So how to answer this question? Clearly, simply, you may have a lateral view. So this is a 7-up bottle. So lateral radiographs are essential. Give us a better insight on the structure that are not readily visible on the frontal radiographs, including the sternum and the thoracic spine. It helps you in the localization of the pulmonary and the mediastinum. It also can help you in confirming any suspected lesion on frontal chest radiographs. And always it's important to check the 3 clear spaces on lateral radiographs: the retrotracheal space, the space, radiograph, space, retrosternal space, and there's the posterior clear space overlying the lower thoracic spine. There's the retrotracheal space, or the so-called Rader's triangle, which is located between the trachea, the aorta, aortic arch, and the anterior aspect of the spine. Definitely, the right hilum is located usually anterior and inferior to the left hilum. So this is an example of a trauma. Trauma patient, front radiograph is totally normal. On the lateral view, definitely you'll see that there's abnormality at the level of the sternum. There is malalignment of the sternum. So this is the CT scan that's done the patient later on, showing like separation of the manubriosternal junction. So this patient had the traumatic injury to the manubriosternal structure, and the patient underwent surgery. So there's no way you can make this diagnosis on frontal radiograph. On lateral view, it's very simply detected. This patient had a frontal radiograph. Again, grossly nothing obvious. However, on the lateral view, you can easily detect that there is a destructive process involving the thoracic spine, where there is loss of height, destruction of the disc space with the sclerosis. You can see it in a better way on CT scan, and that was a case of chronic spondylodiscitis. The example that I showed you on the frontal radiograph presentation. So the lateral view help you in localizing the lesion. because on the frontal view, the lesion looks like as if it's arising from the left hilum. However, on the lateral view, you see that if the lesion is arising from the left hilum, it should be located here, not here. In addition, you see the lung, the primary vessels are passing through the lesion. So this is obviously, based on these two things, this is obviously a mediastinal rather than hilar lesion. So frontal lateral radiograph help you in localizing the location of the lesion. Lateral views as well can help you in assessing the hilar enlargement. So this is a case of hilar enlargement, another case of hilar enlargement. So is it like vascular enlargement or lymph node enlargement? Clearly on the lateral view, you see in case of vascular engorgement, there's enlargement of the hilar, but this is a smooth, okay, and there's no increased density. However, in case of hilar adenopathy, you'll see that there is a full circle of increasing density around the level of the hila, reflecting what we call it the donut sign, and you see a regular contour of the hila. So this is hilar adenopathy, and this is like, so in this case, you know that this patient probably will need to do echocardiography. However, in the second case here, the patient should go for like CT scan to detect the cause of the lymphadenopathy. So the clear spaces, one of them will be the retrosternal clear space. And this is like in the intermediastinal area. And the common diseases here include the lymphoma, I mean the 5 Ts that we all know, in addition to any structures related to the sternum, wounds, etc. So this is an example of a patient with a frontal radiograph showing lobulated density projecting over the AP window. However, on the lateral view, you can clearly detect that this lesion is located within the anterior mediastinum because you lose the lucency of the retrosternal space or the anterior clear space. The retrotracheal clear space is, as I mentioned, the space located between the trachea, the aortic arch, and the anterior aspect of the vertebra. Here you may see obliteration related to vascular abnormalities, esophageal diseases, lung cancer, thyroid lesions, vertebral lesions, etc. I will show you an example. So this patient presenting with acute chest and neck pain. So the frontal view may show maybe some widening of the mediastinum. This is not very clear. However, on the lateral view, you will see that this is the trachea, there's anterior bowing of the trachea, and the retrotracheal space is no more lucent, it's obliterated. So we thought that there's like esophageal pathology, whatever, so the patient underwent esophagogram, so you see that there's kind of significant filling defect overlying the sternum, the esophagus. There was no leak or perforations, so we're still not sure what kind of lesion is this. So we did a CT scan. CT scan showed that there is a retroesophageal collection. It turned to be an abscess, but more dangerously, you see that there is like outbreak within the aortic wall, and there is like saccular projection, contained leak from the aorta, reflecting mycotic aneurysm. So this was an urgent finding, and the patient underwent definite drainage of the abscess and aortic stenting. The retrocardiac clear space, as I mentioned, is the third space you have to assess on your lateral radiograph. So common diseases here include hiatus hernia, esophageal diseases, pneumonia, as I showed you in the previous example, pleural effusions, or if there's enlargement of the left ventricle, the left ventricle will enlarge posteriorly. So this is an example of hiatus hernia where you see a big mass here with air surrounded by air. So this was a simple example of obliteration of the retrocardiac space or the posterior clear space. So your take-home message here is that you have to read the chest radiographs systematically. For me, this is the approach that I follow. I don't mind if you follow any approach that you may like. However, be always consistent and systematic in reading the X-rays. Will make you this ensure that you will not miss a major finding. If an abnormality is not visible, particularly in the exam setting, always check the target zones. Remember to be careful to avoid satisfaction of search, and this can be avoided, as I mentioned, by following the systematic approach. Later radiographs add very important information on structures not readily visible on frontal radiographs.